Welcome to a special edition of the Dermpath Unknowns. Usually we do it a Kahoot, so we call it the Dermpath Kahoot, but we don't always use a Kahoot. But today we have three very, very special guests today, right? So we have our regular fellow, Dr. Colleen Beatty, and we also have Dr. Luke Johnson from the University of Utah and Dr. Michelle Tarbox from Texas Tech University. And of course, Luke and Michelle are the fantastic co-hosts of the widely consumed Dermosphere podcast. And I just found out about it this year, and it kind of just reconnected with Luke this year. He rotated through Dermpath quite a long time ago when I was still fairly green, if I recall correctly. And we had an especially good time with Luke around the scope, chit-chatting about Dungeons and Dragons and gaming and maybe a little Dermpath too. And I always wondered what happened to Luke, and it turns out he went to Texas Tech and went to Utah. I know Aaron Seacrest out there too. He came through the University of Pittsburgh. Really a great guy. Miss that guy. But welcome, Michelle, and welcome, Luke, and thank you for taking part in our Dermpath Unknowns this week.
Thank you for having us. We're so excited to be here.
Yes, and of course you were also on our podcast, and if anybody wants to check that out, it was episode 62.
Episode 62. I can't tell you, like I said, how many former residents and attendings came by and said, we heard you on the Dermosphere podcast, and it's like I didn't have to go out and advertise it at all. Everybody just was able to hear it. So thank you for having me on.
Yay.
So we have 10 cases today. These are great cases, if I don't say so myself. Actually, I can't even take credit for all these cases. Several of these cases came from Georgetown University MedStar Health, from Michael Cardis. He is the director of Dermpath out there. And two of their pediatric dermatologists, some fantastic cases. So they do a yearly peds CPC, and I stole three of their cases because they were so good. So there's 10 cases. There's clinical images on each of the cases, and there's Dermpath on each of these cases. And I thought it would be really great to have experts like you guys talk about these cases somewhat cold, and kind of work through how you approach the case, if they had walked kind of through your clinic. And I do this every week, but people get tired of hearing my approach, and it's good to hear everybody else's approach too. So if that's okay with you guys, maybe that's the way that we'll handle it today, is kind of have you walk through the findings or pimp the residents, as you wish, and then go through the clinical and go through the path. And Dr. Beatty will man the chat for us so that we don't have to keep looking at the chat box, and then pipe in whenever she sees a real good question come out from the audience. And how's that plan sound?
That sounds great.
Okay.
Do we want to mention that we have residents from both of our home institutions represented?
Yeah, so how many are represented there today?
Ooh, right now in person we have 4 people, and we have, I think, some people on the chat virtually as well.
Oh, okay, great.
And
Awesome.
I feel like we've got at least one.
2.
Shout out to Dr. Mujahid. There might be somebody else in there that I'm just not seeing on the Zoom.
And like I said, I don't know how many people. I can't. I've never done the Twitch thing before, so I don't know how many are actually watching on
and
Twitch.
Dr. Topham.
Awesome.
Yep, they're saying in the chat too from Utah.
Represent.
Yep.
I like that. I'm pretty impressed by that.
Our sign for the University of Utah is not too different than like the guns up from Texas Tech.
Uh-huh.
So
Pretty
it
similar.
only makes sense that we're
We're
united.
about to break it apart. Yeah.
That's also the U, of Miami.
That is exactly-
U
Oh,
Miami.
yes, you-
Yeah, they call themselves the U, but how many U's are in the University of Miami? compared to
Exactly.
us?
I love that.
All right, so here's our first case. So this comes from Dr. Habishian. I'm not sure that I'm able to pronounce the first name. Kyan Habishian. And this is obviously a young kid, has some lesions. Well, I'll let you describe, or I'll let you pimp the residence. Your choice.
All right.
So I think this is a pretty classic presentation for this condition. So I would describe these as flat-topped pink-purple papules over the knuckles of the left hand. If you guys want to put in the chat what you think is going on, I suspect you'll be correct. But this isn't the only picture we have.
Yeah, so we have 3 pictures. Got one on the foot. Some lesions
Similar looking
here.
findings there.
Yep. People are already weighing in dermatomyositis. We have 2 votes for DM.
Well, maybe this next picture will change your mind.
Oop.
But it shouldn't, because it also looks like dermatomyositis.
So I have a question. So I have 4 kids. Their knees always look like this. Should I be worried about dermatomyositis? Should I biopsy them? Or should I just run them under the sink?
I mean, you know, run them over the sink, buy them some really fetching knee pads, something to protect from that frictional dermatosis that's probably just normal in childhood for a lot of cases. I think the most telling clinical photos here are the one you just showed. And then I believe there's another one that follows it. The knees by themselves, though, I wouldn't hang the diagnosis on just the knees. So the knees are the, I think, less classical part of the physical presentation, but also good to think about.
Now, is there anything about these that you know, if you just had the knees, you'd be like, you know, maybe the telangiectasias, maybe the degree of scale, maybe, you know, the surrounding skin, other than this, that kind of clues you into, you know, maybe that's bilateral, that something systemic is going on?
There's a very faint violet color to the background. Is that what you were going to say, Luke?
Yeah.
No, I was going to say, just looking at this, I don't think they look like abnormal knees. You'd need context. You need to be able to look closely and do the full physical exam.
I think that, and I may be confabulating it, but I think that compared to what I'm used to seeing with like frictional keratosis of the knees, which, fun fact, sometimes you have something there called a prayer callus, because they would get them in like nunneries, like people who would pray on their knees a lot would get those. So that's one of the names for them, but they also have other names, and you see them all the time in people who do construction work and people who do activities. But usually it's more just of a hyperkeratosis without any inflammation. And the knees do look like they have inflammation behind the hyperkeratosis and color change. So I think that would maybe be a distinguishing factor between that and the normal, like little kid running around on their knees that you would normally see.
Okay.
For lack of
Good tips. So let's
And I would
go.
just go ahead and start all your kids on hydroxychloroquine.
Not ivermectin.
They can't get it anymore. It's so good at beating COVID.
Can you guys leave our drugs alone? Because that would be great.
All right, so here's the slide. This is a digital slide, and the way that, and maybe we can take turns, or maybe we can have you talk about your approach, Michelle. But I can go first and kind of start things off. So, as I always say, when I look at this slide, the first thing that I do is I take a stab at where it was from and how old the patient is, and the collagen here looks very springy, and the fat here looks very kind of lobular also. So to me, this is a very young child already. And secondly, and this is, you know, obviously dependent on the kid too, but secondly, I look at the periphery and I like to see if I can tell where this is from. So this has hyperkeratosis, has lamina lucida, has a pretty prominent granular layer, has a lot of eccrine ducts. So to me, this is acral. So acral things in a kid, you know, my differential diagnosis is already kind of dialing down. And then the money is here in the papillary dermis and at the junction. So I'm going to go to higher power right here, and it's a little bit thinned here, and I can see a little bit of basilar vacuolization, and I can confirm that there's some interface damage here because we have pigment incontinence. And then I look at the inflammation and what kind of cells populate it. So to me, these are mainly lymphocytes. So this basically is confirmatory of some sort of connective tissue disease, and in this context, as you guys noted, dermatomyositis. And then for fun, we can look for connective tissue mucin, but I can't say that I see anything here. So I'd love to hear how you approach these, Michelle.
I like that you have that algorithm, and I think that's such an important thing to have, because if you just haphazardly look at the slide, you can have distracting injuries that take your attention away from the important diagnostic element. You can have something that's a non-relevant, like incidental finding that catches your attention. So I like to teach reading dermpath slides like we teach reading x-rays, right? So you have an algorithm that you follow each time so that you can make sure that you're addressing the entirety of the specimen and not missing anything important. I think that thinking about where the tumor comes from, or not the tumor, where the biopsy comes from, and maybe the context, like the age of the patient, is a really good idea too. Like if we see a specimen and we see a lot of ciliary elastosis, we see a lot of reactive keratinocyte atypia, our brain's going to go to a different place than when we see this beautiful hot pink dermal collagen that is the collagen of youth that makes me happy. I always like to ask other dermatopathologists, does like ciliary elastosis under the microscope make you kind of sad, just like a little bit?
Yeah,
a lot. You're like, oh.
Well, you know, I had a fellow with me, his name's Saurav Ray, and he used to say, every time we saw something with a lot of solar elastosis, he'd say, if we could only harness the power of solar elastosis. Or maybe it was actinic keratosis, but he got a thrill out of it.
It's really impressive. Sometimes you look at the dermis and it looks like soup. It's very sad when that happens. But after you kind of get that general gestalt of, you know, maybe what's the age, maybe what's the location, I think those are great things to think about. Then I'd start at the top and work my way down. So I look at the stratum corneum, see if it's normal or not, which gives you some indicator as to chronicity. You look at the epidermis and you look for inflammatory patterns to see if you have spongiotic inflammation, if you have interface inflammation. And then you proceed to examine the dermis and the perivascular spaces, make sure then to examine the subcutis and anything perineural. And I think that if you do kind of progression through a slide like that, you won't miss your important clues or be distracted by an incidental finding. So I definitely agree an algorithm is so important. And in this specimen, looking at it, you know, right off the bat, you can see that there's some chronicity to it. There's a lot of hyperkeratosis. You can appreciate that there's some reactive epidermal changes. And then when you get up closer, you can appreciate the vacuolar alteration at the basement membrane and the strong perivascular inflammation. Now, sometimes learners get confused because we teach dermatomyositis itself as kind of subtle, right? So like dermatomyositis, let's say you biopsied like the Schall sign of a patient that had dermatomyositis. The findings there would be really minimal for most patients. They'd have some mild vacuolar interface, maybe very scant perivascular and a lot of mucin. We have to remember that Gauthron's type papules and that kind of sign on the acral skin and the surfaces is where dermatomyositis kind of shows off. And so you get the kind of more impressive findings in that area. So I think that that's a fine point that sometimes confuses people, and thinking of it that way has helped me kind of explain it in the past.
Yeah, and I always tell the residents, in anything that's inflammatory, you got to remember that there's a spectrum of changes, especially from early to late. And everybody's always looking for the basement membrane changes. Maybe we have some here, but that's the one thing that I almost never see unless it's a super, super late lesion.
I totally agree with that. It's nice to see it when you have it, but
Yeah.
it's kind of cool. I think of it like a car that's been out in a hailstorm. We get a lot of hail. That's one of the things we sometimes get. But like when you get a car that's been out in a hailstorm, if you think about the hood of the car and how it can get beaten up by the hail, and then if you tried to look at that like straight on edge after the hailstorm, it would look kind of fluffy and thickened, even though the individual membrane itself is very similar thickness. It's just damaged from the inflammation.
So, Colleen, you got any PIMP questions for the residents?
More I was just going to ask kind of from a trainee perspective, Dr. Johnson, how do you manage DM like juvenile dermatomyositis, and kind of are you worried about anything that we're not thinking about in typical adult patients with dermatomyositis? I guess the malignancy risk isn't there in children, correct?
Well, yeah, obviously we do this in combination with our rheumatology colleagues. Though, interestingly, they have protocols for telling how active somebody's dermatomyositis is. And in kids, the skin plays a bigger role in that algorithm than it does in adults. So there's a bit of an extra impetus for us to try to treat their skin disease. Unfortunately, as we know, the skin is hard to treat in dermatomyositis. So the treatments are similar to the treatments we use in adults, topical steroids and sun protection and hydroxychloroquine and, systemic immunosuppressants and things like that.
All right, let's move on to the next case.
Awesome.
We warmed up with our first case. We took a little long, so we're definitely going to have to pick it up here. All right, so this is our second case here, and I'll just hand it off right over to Luke.
To me, my second case looks a lot like my face. Is everybody else just seeing my face?
I am seeing
Yes.
your face.
There you
Second
go.
case or second
Lovely
face?
face.
All right. So, residents, what color is this? It's yellow-orange. There's not a lot of stuff in the skin that's yellow, so especially if this is a child, you probably think it is.
It made me want to do my Adele joke, which is yellow, it's pink, because it's both. Anyway, sorry, go ahead.
You still got it, Michelle.
Flavonoid making an appearance. All right.
So this is pretty good for a juvenile xanthogranuloma. The natural history of these is that they spontaneously involute over the course of years, and I feel like they look fairly distinct clinically, so I usually don't biopsy them. The reason you might is if they're in a cosmetically sensitive area, or if they're just annoying or something, you could remove them, with the caveat to the parents, of course, that they'll probably go away eventually on their own. If there are a lot of them, or if they are close to the eye, then people can potentially get them intraocularly, and then if they do have one intraocularly, they can bleed into the anterior chamber, which is something called a hyphema, which can lead to permanent blindness. So those are like referring people to ophtho if they have lots of Jxgs, like more than 3, or if they have them close to the eyes. Really the only management I do besides reassurance for these, assuming path is confirmatory in this case.
Yeah, so of course a biopsy was done, and here's a shave biopsy of a rather large, you can kind of get an idea of the size of a biopsy, even if you don't know what magnification you're on, by how big the epidermis is. And obviously this is thin, but it's also really broad. So this is a large nodule, and it's obviously got some hyperkeratosis, but a dermis that's completely filled with cells. And one clue when you see a tumor, in the dermis, is what color it is. And so this one is not as blue as a melanoma or something that's very dense that has a lot of nuclei. So this has a lot of cytoplasm, and it's kind of a blue cytoplasm. So there aren't that many things in this differential diagnosis either. And then since they all look the same, no matter where you go on higher power, it's going to look, the cells are all going to be the same types of cells. Well, we do have some clear areas and some smaller blue areas here too. So we'll go on higher power and kind of scoot around. Not screw around, scoot around. Some of them are epithelial.
That's technically kind of like that, so you could say that. Stay under the microscope.
So, I'll hand it off to you here, Michelle. So on a higher power, I'll scoot around.
So, thank you for doing that. I appreciate that. I think you described it really beautifully, talking about the color. And I think that color can be really informative for dermatopathology. So what we're seeing here is that there's a lot of cytoplasm, but it's not terribly pink. There's some, pink background to it, but it's a little bit more amphophilic almost. And then you are seeing kind of back-to-back sort of fluffy histiocytes. There's also some little areas where you've got some sclerosis, and you've got a sort of attenuated epidermis sort of stretched over the top. But the beautiful part of this case is one of my favorite things in dermatopathology, which is the Teuton giant cell. And when I was very first learning this as a brand new baby derm resident, I had a hard time getting Teuton to stick in my face because the Teutonic warriors are something that is important in history and whatever. And I was like, how do I connect this? But then I started thinking about it sounds like Teuton. I was like, Tannenbaum, and that's like a Christmas tree. And these remind me of a Christmas wreath with snow on it. So that helped me remember it. And of course, I don't have to use those tricks now, but if you're having trouble, think of it like a Christmas wreath with snow on it. And you'll be like, oh, Tannenbaum, oh, Teuton giant cells, you are a Jxg. So I think that's one of the most pretty things that you see. Now, it is important to point out those are not present in all Jxgs. So early Jxgs often lack well-developed Teuton giant cells, but they'll have all of the other elements. So in mixed inflammatory infiltrate, you'll see foamy histiocytes, usually that good silhouette where you have the attenuated epidermis over a nodular proliferation, maybe some of the little bit of sclerosis. So do you have a trick for early Jxgs?
Do I?
Yeah.
I don't have any tricks.
Yeah, my only thing is like looking at the shape and the color and seeing what I should expect. Like I already look at it going, that looks like it's going to be a Jxg. And if you're just missing the Teuton giant cells, you just confirm it's not anything else in the differential.
Yeah, so I like to also order a factor 13A on not every one of these, but anything that doesn't have all the classic features, just to make sure it falls into the xanthogranuloma family. But that's about it.
And one other point I always make with these things is in a child, completely harmless, probably will go away on its own unless they're severe and multiple. In an adult, you need to go looking for lymphoreticular disease. So an adult with new onset Xgs, we probably don't call them juvenile at that stage, but an adult with a xanthogranuloma that comes out of nowhere might have a higher risk for having a leukemia or lymphoma. I've had a couple of patients that were adults that had Xgs arise, and then they got diagnosed, one with adult Langerhans cell histiocytosis, another one with CLL, and another one with CML.
All right. Anything from the trainee side, Colleen?
I think just the triple association of Jxg, kind of Dr. Tarbox was already touching on it, but Jxg, NF, and what makes up, you can type in the chat, what makes up the rest of that triple association that you need to worry about. Perfect. JMML.
All right. We'll move to the next case. Case 3. Okay. I think we have 2 patients here. Not in this picture, but... So we have a lower limb of a newborn. So take it away, Luke.
So, especially if this is like in the newborn nursery or something, this is something you get consulted on. Patient with vesicles, we're worried about herpes, that kind of thing. And you come and you can kind of see these erythematous patches and vesicles and papules. They kind of track along maybe Blaschko's lines if you squint. We've got 1 or 2 more pictures here as well.
Mm-hmm.
It's a baby girl, in all likelihood.
So that's a good pimping question for the chat. So you keep going, but people in the chat, why is it likely to be a girl?
1 more picture here. So this is a different patient, I think, with a little bit of a different presentation. But these vesicles, sometimes they look like pustules, kind of track along the extremities and the trunk in these linear and whorled patterns. And a biopsy can really clinch the diagnosis, though, of course, we should be thinking of it. You can write down what you think is going on here in the chat, guys.
Yeah, so we had a vote for IP already, and then to answer the question about why it's more common in females, we have X-linked dominant and fatal in males.
There are rare case reports of males with this that had germline mosaicism that survived.
Yes, or an XXY karyotype.
And what else does this usually come in with a differential as for you guys?
Oh yeah, for sure. I mean, I think the one people are the most afraid of is some kind of infection in the neonatal period, like disseminated herpes or zoster, or potentially like severe like impetigo, because of the pustular nature. I think that's usually the first concern.
Torch infection. But, you know, everybody is justifiably worried about herpes, so they often will already be doing herpes stuff, herpes treatment and so on by the time you arrive, which I think is reasonable. Herpes can look like a lot of different things, and the treatment's pretty safe, but the biopsy can really help us clinch the diagnosis and be able to withdraw those things.
Okay, speaking of the biopsy, here it is. So we actually have 2 slides for you. So these are interesting because, so here's a punch biopsy. And again, you can notice kind of the smaller fat and the springy collagen, nice red color. And then the money is up here. And so we have hyperkeratosis, and we have these eosinophilic microabscesses, lots and lots of eosinophils everywhere. So kind of like a sponge derm on steroids. So,
Or off steroids, because
Off
steroids would be breeding
steroids.
sponge derm.
It is such a pretty slide.
Yeah, so anything else you want to glean from this slide, Michelle?
Oh, for sure. So the things that I admire very much about this, first of all, you have this really nice hyperkeratotic element that's not always there early on, but you can appreciate that you have that part of it overlying that follicular orifice. And you saw that in some of the pictures that some of the lesions were keratotic. You also see that there's this really impressive invasion of the epidermis by eosinophils. And here they're even making a frank pustule, which you sometimes will see in this condition, along with dyskeratosis. So we have that eosinophilic infiltration of the epidermis and dyskeratotic keratinocytes within the epidermis. You see those 2 things together over the top of normal looking collagen, like healthy young collagen. IP is a pretty darn good bet. This degree of eosinophilic spongiosis is too severe for most things that you would even think about with eosinophilic sponge. So with eosinophilic sponge, you'd also think of things like, a patient might have bullous pemphigoid, and it might be an urticarial lesion of that condition. That wouldn't necessarily have as much dyskeratosis, and it usually doesn't have this level of impressive invasion by the eosinophils into the epidermis. But yeah, I think it's a beautiful slide.
Yeah. Go ahead.
Sorry. We have a question in the chat regarding, could you consider LCH based on the path differential?
Langerhans cell histiocytosis, eosinophils like to hang out with Langerhans cells, but the predominating cell in this is definitely the eosinophils. There's not really good mononuclear cell infiltrate. It definitely can have some crossover, I think, in terms of the appearance of acute lesions and, the collections of the cells in the epidermis, but it's just such a predominance of eosinophils for me. What do you think?
Yeah, I agree. There's no Langerhans cells here to speak of, and even if they were, they're probably dendritic and not epithelioid. So usually you can see those from low power also. These, like you said, the striking thing is the eosinophils. And I also want to add that, in a severe sponge derm, in a young patient, there's not that many things in the differential, especially this young. And another clue that this is a very young patient is, not a whole lot of sebaceous glands here, and these really small kind of vellus hairs too. So the context really helps you. Even if you didn't have any clinical information, I think this would still be at the top of your differential.
Definitely.
So
Folks in the chat, what is the most important subspecialty to refer these patients to early?
The most important subspecialty to refer IP patients to early.
Though the good news is that most patients do fine. It stands for incontinentia pigmenti, of course, and Dr. Alfie Kroll, my senior mentor in fellowship, sometimes called it inconsequentia pigmenti. And people and parents of children who have it bad might be offended by that, I suppose. But I try to be reassuring because sometimes parents have been really scared by other providers.
So we have a vote.
We have an Echo. I used to have a Toyota Echo, but I sold it in Texas.
We have a vote for ophtho, dentistry, and neuro.
Ophtho is the answer. So they need pretty frequent ophtho follow-up, and ophtho, of course, knows the protocol. Neuro, I usually don't send them to unless they develop signs or symptoms, because a lot of kids with IP don't actually end up having neurologic issues. And then dentistry is important, but they're not going to develop teeth until they're about a year old, so that's when you want them to go to dentistry.
So here's another biopsy from a different patient. And as I mentioned before, inflammatory things have a course, a time course. And in fact, Bernie Ackerman had a book called The Lives of Lesions. And this is a later lesion, and this is a really pretty finding that you don't always see, rarely see actually. So the scaly lesions can have dyskeratosis, but they can also have kind of these whorly things too here. So later lesions don't look the same as early lesions. Okay.
Yeah, you don't quite get that impressive preponderance of intraepidermal eosinophils in the more mature lesions, but you still usually have some, along with dyskeratosis, so you're still usually able to make the diagnosis really well. The past one was so infiltrated by the eosinophils that had an eosinophilic pustule, which that's a pretty unusual thing too. You can see eosinophilic pustules in certain things, including like pemphigus vegitans, but it's not super common.
Okay, moving along to the next case. Anything else, Colleen?
I guess so when this later stage would be more like verrucous, the second
Kind of in
biopsy?
between, I would say. In
Yeah.
between.
Okay.
Okay. So we only have one picture here, and I think this is your picture, right, Colleen?
Yes, this was a case from Morgantown.
So this is a brand new baby, and we'll say that they are a healthy term baby. And if you were to palpate this, I think you would feel some induration on that discolored patch there.
Yes.
Mm-hmm.
I think they also had a history of potentially hypothermia, like hypothermic cooling. So we already have a vote for subcutaneous fat necrosis of the newborn.
Well, we do have a biopsy, so that should give us the answer if it's subcutaneous fat necrosis of the newborn.
Yeah, so maybe instead of monopolizing the initial read, maybe Michelle can take the initial shot.
So just like you were talking about, when you first kind of look over, I like to do that kind of bird's eye view. And when I'm doing my bird's eye view, I'm doing a couple of things. Actually, the way I start looking at a slide is I actually pick it up and look at how many pieces I'm supposed to be looking at, count, and make sure I'm going to see all of those. Then I look through the scanning optic and I try to see where do I think the action is in the specimen, like where is the diagnosis going to sit. Now I still start at the top and work my way down so I don't miss anything. But you can kind of tell with this specimen that the exciting part is deeper in the specimen. So I would proceed through the exam of the normal stratum corneum and the nice happy looking epidermis. Really beautiful collagen in the dermis, a little hypercellular, but you kind of see that in young patients. So I might think that this is probably a younger patient, like a baby. But the real beauty of the specimen is when you get into the dermis. And what you see there is sort of a mixed inflammatory infiltrate invading part of the lobule of fat. And you can see that there's some adipocytes that don't look so healthy there, that have some clefts in them that are somewhat radially oriented. You also see some areas where there's quite a lot of inflammatory cells. Some of the little rays are within what look more like histiocytes, and some of them are within adipocytes. And there's a mixed inflammatory infiltrate. That mixed inflammatory infiltrate does help you distinguish this condition from one of its histologic mimickers. So there's inflammation here. This baby lived long enough for the inflammation to happen and show up in the biopsy. If you happen to be unfortunate enough to be part of the care of a baby suffering from sclerema neonatorum, which is one of the other conditions we consider in this differential, usually much sicker babies who are preemies, they often don't live long enough for the inflammation to even become a part of the presentation of the pathology. So the presence of the inflammation kind of points more towards subcutaneous fat necrosis of the newborn. What is the other histologic mimic of subcutaneous fat necrosis of the newborn? Can happen in any age. You guys like in the chat, you can put that in. And then I also have a good pimping question, which is what is the metabolic anomaly that can follow subcutaneous fat necrosis of the newborn? So you can put those two things in the chat. So which metabolic abnormality can they get? And what is the histologic mimic of subcutaneous fat necrosis of the newborn?
Yeah, so you're getting answers for post-steroid paniculitis for the mimic, and then lots of hypercalcemias.
Yay! Good job.
Which is relevant from a management standpoint. So there are some guidelines that say you should not supplement these babies with vitamin D drops like you do with most babies. I've had patients who have just like a little tiny piece of subcutaneous fat necrosis of the newborn, and it's hard to imagine that that's going to cause enough trouble to actually withhold their vitamin D. So I just sort of tell the pediatrician this information and kind of let them decide what to do about the vitamin D.
All right. Anything else, Colleen?
No, I think we're good.
Okay.
Next
We'll
case.
move to the next case. So this comes from Dr. Kerkorian at MedStar. Beautiful case. Let's start off with the first picture. We have 3 pictures here.
Well, this is a little kid. This is fairly dramatic. You've got this fungating pink tumor. I would call it exophytic. If I was thinking about fruit, I might say it looks a little bit like a raspberry. It's got hypopigmentation extending onto the neck with some hyperpigmentation admixed. It's tough to say exactly what's going on up there with, I assume that's the ear.
Mm-hmm.
If there's a sort of a soft exophytic papular nodule there too. And then beautiful blasco-linear hypopigmentation along with this sort of speckled appearance along the lateral edges.
Clearly, this is a different patient from this one.
A little older.
Yeah.
And then more of these raspberry-looking papillomas, if you will, with, again, this pigmentation disorder. Hypo and hyperpigmentation admixed together.
Yeah, so when I first saw this picture, I was like, maybe that's subcu or fat herniation, but I think actually it's probably the papillomas kind of extending down here. Okay.
If I did not already know the answer to this, I'm not sure I would get it just from looking at this. I've never seen one of these patients in real life. But in the chat, you guys can write down a pediatric dermatologist's favorite pimp question answer. What's the gene mutation?
The gene mutation for this disease.
And you can write down a few other clinical features you can see in them too if you feel like it.
A
Yeah,
multitude
great.
of clinical features.
So we have the raspberry papillomas of Goltz, and then the gene PORCN, which I think stands for porcupine gene.
I didn't actually know that's what it
Me
stood
neither.
for.
All right, so residents, which one of the clinical findings do we have here? So we have a biopsy here, a shaved biopsy, multiple fragments. Yeah, this is the papilloma. So from a path perspective, there's not a whole lot to say for this. You know, it could be a wart, could be something, any number of things that's papillomatous. If it's on the oral cavity, you might see some clear cells, which we don't here, but that would be a verruciform xanthoma. But, you know, overall, a very interesting case. You can also get pyogenic granulomas here. You can get alopecia. You can get nail findings. You know, many, many findings. Lots to pimp about here, right?
The other name for Goltz is focal dermohypoplasia, so you could probably see those sorts of findings on path as well.
Yep.
And then I always remember they can get the lobster claw deformities.
And when I was looking over this case, I actually thought it would be an amazing pimping case because you've got these strawberry papillomas, their histopathology, and somewhat their clinical is somewhat reminiscent of a verruciform xanthoma. And there's another genodermatosis that can create whorled pigmentation or maybe blascoid pigmentation that you can appreciate a blascoid texture change that's associated with a verruciform xanthoma. So that's another good pimping question is which of the genodermatoses that can have blascolinear findings is associated with a verruciform xanthoma, which I think would be really hard. Like that would be a good way to write a really difficult question, right? Because you have two entities that have that blascolinear pigment change that also have papillomas that even at low power on the microscope resemble each other.
Yep, we got answers for child syndrome.
Yay! And then do you guys have the gene for that?
Just a Google search away.
I always remembered it with this mnemonic, which is like, do not send your child by DHS or DHL, like the people who were trying to compete with FedEx for a while. So like an FDHL.
And is this patient most likely a female or a male? Tell
That's
us in
good
the
to
chat, F or M. Nobody knows. So female, this is X-linked dominant, right? Am I remember? Yeah, X-linked dominant.
Yeah, I think so. I think child is as well.
Okay. So we'll move on to the next case here. This is a really cool case too. So we have a little bit of an older boy who apparently never heeded his mother's suggestions to wash his neck or around his ears, right?
So he's pretty xerotic, and he has these erosions and shallow ulcers in the neck flexure, as well as some hyperpigmentation there.
And we have another picture.
And then this looks like his abdomen and waistline. He's again got this flaky, hyperpigmented, thin scale overlying pretty raw-looking erythema. And they kind of alternate. So
Yes.
this one would be tough without some context. And Colleen, I think you had some context for this patient.
Yeah, so this child had autism and had a very limited diet. And so some people in the chat have already guessed nutritional deficiency, pellagra.
From Texas Tech, I might add.
Michelle promised she was not feeding them
I'm
answers.
not. I promise I'm not. They can vouch for me. I'm being really good. They're really smart though, so it's not a surprise to me that they're on the right track. That's awesome.
Yeah, so
Do you know about how long it took for this presentation to develop, Colleen?
I don't. I forget some of the details surrounding the case.
The path is such a beautiful illustration too of a couple of things, like how fast this can happen. These kind of crises of loss of the epidermal integrity and stuff can happen relatively quickly with these deficiency states. So like on the pathology, it's really orthokeratotic, but then the epidermis becomes very pale and almost has like ballooning degeneration. And then you can kind of tell it's not an inflammatory process because the dermis is actually relatively quiet. It's getting irritated with the epidermis, but the problem is, coming from a different source. This isn't caused by the inflammation.
yeah, so this one's almost textbook, almost too good to be true. This one
Right.
here. Sometimes you only get this kind of pale look to it. You don't have the necrosis to it. And sometimes most of the epidermis is normal except for the edge, is a little bit paler. And then later lesions, can look like psoriasis. So, but this is such a good case. So good. As Michael used to say, oh, this is so good. So good.
Yeah, it's an awesome example.
So if this is pellagra, that's a deficiency of what?
Mm-hmm.
Which vitamin? B3. Niacin.
Yep. Niacin. Good job, guys.
So which ones of the other nutritional deficiencies, this is a question for Luke, there's a whole bunch, but which ones happen most often in kids? Is it this one? Pellagra?
I don't know the answer. We live in resource-rich America where I don't really see a lot of this. But I would guess kwashiorkor and marasmus are pretty common in resource-poor places of the world in kids.
And if you restricted it to like patients in the kind of newborn to infant age, you might think about like enterodermatitis and neuropathica, or echodermatitis and neuropathica, might be more prominent in that age group. But yeah, I think all of those.
Yeah, and they all looked similar histologically.
Mm-hmm.
All right, so
Do
we'll
you
move
guys
on.
remember any? Oh, sorry. Go ahead.
Go ahead.
I was just gonna say, are there any drugs that can make pellagra happen faster, or that can predispose patients to pellagra? There's a couple we don't usually get it. Other people often do. I always remember like INH for some reason.
Mm-hmm.
Can precipitate that.
Yeah, good job. They got that in the chat.
Yay!
All right, here's the next case. So this is a pretty straightforward one, but there's a lot of discussion to be had here.
Mm-hmm. Management.
So this is a pink-brown papule or possibly plaque on the skin.
Same lesion.
It looks like an extremity.
Uh-huh. Same looks, a little pinker this time.
Mm-hmm.
And then a pretty classic look on path.
Mhm.
So again, young skin, we have a very well circumscribed lesion, a very symmetrical lesion, largely junctional. Don't let this stuff up here scare you, this impera, and a lot of times the nests kind of pop right out of the epidermis too, but they're all still fairly nested, like a bunch of bananas. They're hanging off of the junction a little bit. And they're spindled and epithelioid. So this is a classic first year Spitz nevus. Yeah. So, this is a topic nobody ever gets tired of talking about, is the atypical Spitz tumor. So I would love to hear, I've been at Pittsburgh my whole career, and once a year I get out and get to listen to people talk about this sort of thing. More and more we're doing a lot of molecular tests on this, and sometimes I wonder if we're doing too many. If it looks funny at all, if it has a large dermal component, if it has one look in one area and one look in another area, we don't hesitate anymore to get fish studies. And on top of all that, we have these new NGS panels where we can look for NTRK and ALK and many other things, and I feel like we're kind of rediscovering this lesion in this age of NGS. But I also at the same time feel like maybe we're doing a little too much because we're not really sure what to do with all these lesions. So I'd love to know when you make how you work up an atypical Spitz tumor, and what you guys do with them afterwards.
I totally agree. This is such a hard area of dermatopathology, especially because most of the patients you're dealing with are going to be children or young patients. And there's Spitz nevi that you can look at. You feel happy in your heart. Oh, what a cute Spitz nevi. That's adorable. Nevus, that's adorable. And you sign it out and you let the patient go along with their life. But then there are ones that look a little unusual. And what we're learning as we're doing more molecular studies is that tumors that look weird under the microscope often have genetic changes that explain why they have that phenotype. And that makes sense when you think about it, that the genetics are driving the actual presentation of the condition. What we do with that information is definitely in development. So my personal approach, if it's a young patient, it's a relatively typical looking Spitz. We, clinically also might just observe it. There are specific dermoscopic signs that you look for in Spitz nevi. You can look for their typical regularly distributed dotted vasculature. They're allowed to have kind of a negative network because of the epidermal hyperplasia that can happen as a part of the neoplasm, which is actually a reassuring sign. When you get a thick epidermis with a compound or junctional Spitz nevus, that's normal. I like to say that the epidermis and the nevus, the cells of the Spitz nevus like to play with each other a little bit, so you get a little bit of a thickened epidermis in that setting. And you're right that once it becomes more atypical, maybe you have some features of unusual dermal population, you have some mitotic figures, then you have to think about what am I going to do for this. So if there's atypical features of it, but it doesn't achieve the level of atypia you'd be concerned for melanoma, I think that studying it further to know if there's a greater risk is reasonable. In general, we tend to conservatively re-excise them if they're present, if they're an atypical Spitz tumor, if it's feasible for the person at that age without significant morbidity. Otherwise, sometimes we observe them depending on how well the biopsy removed the lesion or other features of the patient, if they have a high-risk family situation or something like that. But I think this is a state of knowledge that's really in flux. And even in the original paper describing the Spitz nevus, some of those patients did actually have outcomes that would indicate that some of the things, even in that paper that were called Spitz nevi, were either atypical spitzoid tumors or spitzoid melanomas. So it's a difficult diagnosis to make. It's very nuanced. And I think that as we learn more about why the genetics make the cells behave the way that they do, we'll understand better how to use that information.
So what's kind of your go-to language in your comments?
Yes. I'll tell you exactly what I say. The management of Spitzoid neoplasms is controversial. However, and then I give kind of instructions as to what I recommend. So if it's feasible to re-excise it conservatively but completely, I do favor that approach for a couple of reasons. One reason is that you know that it's gone. The other reason is that if you leave it there, it grows back through a scar. It's going to look horrible grown back through a scar. It may still have unusual atypia grown back through a scar. It's much more likely, if it's ever biopsied again, to be called a melanoma. And so you're not doing the patient necessarily a favor by not putting them through the conservative re-excision, because down the line they might end up having to have a big excision and maybe even a sentinel for something that, without the context of the prior biopsy, gets interpreted as Spitzoid melanoma. And we know Spitz nevi go to lymph nodes, like benign Spitz nevi go to lymph nodes. So you can open a Pandora's box if you lymph node biopsy somebody who has a Spitz nevus, and then there's a read that suggests it's in the lymph nodes. So it's a hard thing to manage.
How about at Utah? Something similar?
Well, I rely on our dermatopathologists for a lot of this Spitz nevi stuff. The more I learned about Spitz nevi in fellowship, though, the more I felt like I should think about them like I just think about nevi. So especially if they're in a kid under 12 and I biopsy it and it says Spitz nevus, then it's just like if I biopsied something and it said nevus, so I don't worry about it. If it says it's like mildly atypical, then I usually still don't worry about it. Like I don't worry about a mildly atypical melanocytic nevus. If it's moderate or severe, then I usually will re-excise it because that's what I would do in a non-Spitz nevus that came back that way.
And at what point would you do a node or send them for a node?
I would probably have to be in conversation with the dermatopathologist and decide how worried they were.
And I think depth is important too. Like the hard thing with Spitz nevi though is if they have a dermal component, because the epidermis is so thick, they get deep pretty fast because the epidermis is already so thick and you measure from the granular cell layer. So you may be in that Spitz node, the lymph node territory relatively quickly, even with some sort of superficial reticular dermal invasion. So I think you have to put it all together as a whole picture, who the patient is, what their risk is at baseline, what are the characteristics of the tumor, and also what are the characteristics of the patient. Can they tolerate a re-excision? Are they going to have to go under general anesthesia to have it done? Do they have medical conditions that makes that more dangerous than observing the lesion? So it's a hard decision to make and has to be made with the clinician and the pathologist together, I think.
And how often do you use FISH?
FISH is mostly for things that we just can't classify based off of immunostains and regular routine histology sections. So I would say of the Spitzoid tumors that we deal with, I would say probably 10 to 20% of all the Spitzoid things are atypical enough to consider that kind of workup.
Okay.
But we don't biopsy a ton of them because to biopsy a nevus in a child, I have to be kind of provoked because it's a child. And so their things are going to be developing and growing. Their melanocytes are going to be a little bit bigger and juicier looking because they're young, and they might have mitotic figures because they're growing.
Yeah. So
biopsying things in a child can potentially open up a Pandora's box that you didn't have to open. So I have to be a little bit provoked in a kid. And I'm a big dermoscopy nerd, so I, of course, examine the lesions carefully and will monitor them for change, things like that.
Well, I really appreciated hearing your views on these.
Thank you.
So we will head to the next case. So this is a case, I did take out one picture because it wasn't classic, but so we only have one clinical picture here. And
well, this is a toddler-aged child, looks like, with scattered heme-crusted, mildly erythematous papules on the trunk. Tough to say what those are without more context, but let's get a biopsy. Maybe that'll give us the answer.
Instantly, here's the biopsy, and you can see the scale crust here, a giant scale crust, and a very dense superficial dermal infiltrate here, which is got some clear cells in it. So we have this neutrophilic and hemorrhagic scale crust, some perikeratosis, kind of a thinned epidermis. The epidermis may or may not, it's definitely involved with some of these epithelioid cells here. So these epithelioid cells aren't arranged in any nest or in any particular pattern. They're just kind of, I feel like Michelle would have a good analogy here for some soldiers or something.
I was actually thinking, it looks like a Civil War battle. There's just no organization at all.
No generals leading this charge whatsoever, and then
Bam down on the one side. It's like totally.
Civil War veterans take offense.
I think this is a beautiful slide, and I liked how you brought up that clear space with the inflammatory infiltrate. I think you see that often with this condition. There's sort of space around the cells because there's so much spongiosis. So when you look up closer, you also see that there's this background proliferation of these really nice looking mononuclear cells that have a lot of cytoplasm, and they have nice little bean-shaped nuclei, which is lovely for this diagnosis. So, and then there's a sprinkling of their friends, which are, of course, they include the eosinophils on their friends list that obviously got into the party here. And we've got some lymphocytes, a little bit of hemorrhage. So I think this is a beautiful case. Absolutely beautiful. Are the people getting it in the chat?
Mm-hmm.
Yes, we have several votes for LCH.
Yay! Good times. I love it. So the epidermotropism, or the sort of pagetoid movement, I guess, of the Langerhans cells through the epidermis is sometimes so striking that it looks almost like potentially even like a little tumor nodule. They love to go into the epidermis because they belong there. So Langerhans cells are normal occupants of the epidermis. And sometimes, you get a stain or something that's like showing you, like, what would stain a Langerhans cell, actually? This is a good question. So
In
what
the
would be
chat.
a good... Yes.
What stain? Yeah, we got a 207.
Yep.
Very good. And then what's one that stains other things too that might actually be confusing?
S100. Mm-hmm.
So if you see like a dendritic cell that's S100 positive, but it's above the basement membrane, and there's not melanoma in the rest of the background of the photo you're looking at, you should think about a Langerhans cell instead of a melanocyte. Awesome.
Yeah, I was
Beautiful
gonna
case.
try to see if we can find one, but I don't think there is one here. And sometimes they'll attack the follicular epithelium too, but we don't have that as well. Yeah, so nice case. So in the interest of time, we'll keep moving on here. So
Patient
here,
has some
Go ahead.
tan
Yeah.
macules or papules. There's a few more there.
Some on the back.
And probably you would try rubbing one to see what happened.
Yeah, and so clearly they're pre-potty trained in this photograph, and then now they're a little bit older. This is the same patient.
They
Yeah.
are much more inflamed and numerous now.
Okay, a little
These are-
girl now.
These are fabulous cases.
Yeah, aren't they?
Mm-hmm.
So here on lower power, we have a really big punch biopsy. I can't even zoom out. That's when you know it's really big. And the epidermis is fairly normal, and then you have this population of cells here in the upper dermis, and then the rest of the skin is fairly unremarkable. So the money is here. That's where we're going for the money. Money is right here. Maybe a little spongiosis over to the right here. And then these are all the same type of cell, and they're all a little bit granular.
Mm-hmm.
And everybody likes to use the term fried egg for this. I don't know. I guess it's a fried egg. Sunny
Definitely
side
fried
up.
egg.
Okay, so yeah, we
We
got
have some votes for
mastocytosis.
mastocytosis.
Yeah, great job, guys.
Awesome. Sometimes the mast cells are so densely packed they actually look like a nevus, and so you have to like really take a minute and look at the cells and see if you can tell that the cytoplasm, that granular cytoplasm of the mast cells, or if it's that amphiphilic cytoplasm that's a little more homogeneous for the melanocytes.
Good news is that usually mastocytomas are rather inconsequential, even when people have, a fair amount of them. If people have a whole bunch of them, like maybe over 20, I might ask them physical exam questions or review of systems questions. I'll probably do that anyway, to see if they have just like too much histamine getting released into their systems. You can ask them about abdominal pain and diarrhea and wheezing and stuff like that. And you can check a tryptase level if you really feel inspired. If it's over 25, then you can start to be concerned that they really do have a large mast cell burden, just squirting out a ton of histamine.
And that's a stain that we can do too. We can do a tryptase stain or a C-kit or any of the metachromatic stains that help highlight the granules, like a Giemsa stain. So I wanted to ask you, I don't know exactly what happened in this patient, but why would you think that this has stuck around for so long and kind of progressed?
So we used to think that mastocytomas would sort of slowly go away over time, but there was a study a few years ago that said oftentimes they stick around, but they rarely bother anybody. So this particular case of them sort of getting worse over time was pretty unusual. So this is a patient where I would be a little bit more concerned that there was maybe something systemic going on and they would need further workup.
Yeah, I wonder if she had anything. Okay. Anything else from your side, the trainee side, Colleen?
If you were going to work someone up, what is a serum test that you do? What lab would you order? In the chat.
One other management thing, if I have a patient that has multiple mastocytomas or urticaria pigmentosa or TMAP, I do like to make sure that they at least have access to an EpiPen, because they can be at greater risk for anaphylaxis, especially if they get stung by something in the Hymenoptera family. And so just making them aware of that, I think, is appropriate. And then I also talk to them about anytime they need anything where they might need general anesthesia, they need to make sure that the person taking care of them understands that they have mastocytosis and that there are certain anesthetic agents that they shouldn't actually be exposed to.
Mm-hmm.
All right, moving on to the last. Is this the last case?
Yep.
Yeah, this is the last case, so we're doing good. We start a little late and we'll end a little bit late.
Thank you guys for being so kind about that.
Oh, no,
So
no.
this is a child, probably looks school age, and with a large pink papular nodule on the chin. There's not a lot else going on the skin. So this could be a lot of different things.
Yeah,
It's
so
rather nondescript.
I'll give you a little bit more history on this patient. It didn't grow anything out and went away on its own after months and months and months. And it's not acne.
I'll let
No,
the,
not
people in the chat have a whack at it.
So people are guessing lymphoma versus pseudolymphoma, pseudolymphoma.
Those could look like this, but that's not what this is.
We got it.
Somebody got it.
Somebody
Yeah.
got it without the path.
That's right.
See, who needs path? We're disposable. So here's the
Except for Spitz
biopsy.
Levi.
So here's a biopsy, a nice deep punch biopsy, and then we almost have a Gren zone here, and then we have this really dense mixed infiltrate, and then you can tell how friable the biopsy is because it's like just falling apart here, just falling apart. And then on higher power, it's mixed lymphocytes, histiocytes, a bit granulomatous, and I'll tell you all the bug stains were negative. So this is an area that's a little bit more granulomatous here.
So you're saying it was aseptic.
Aseptic, one might say. So this
And
is
it was on the face. And you said it was
it
granulomatous.
was granulomatous.
And who knows why it was
Yeah,
there?
who knows?
Nobody.
Nobody knows. So Dr. Crow got the diagnosis. This is an idiopathic, well, she said aseptic facial granuloma. This could also be termed an idiopathic facial aseptic granuloma. This is something that was new to me over the course of my career. It's not something that I learned in residency, but pretty classic history. You know, a bump that looks like really bad acne that doesn't go away for a little while and never grows any organisms. I'm not sure if there's
I think
anything.
I learned about this in fellowship, so it is perhaps under-recognized, but I find it... I'm talking about it more and more lately. It's thought to be a variant of granulomatous rosacea. You can try to treat it with ILK. The average time it takes them to go away on their own is 11 months. In my experience, most people don't want to wait that long. I've excised a couple of these.
And there's something kind of like it that happens on the scalp, the aseptic, sometimes alopecic nodules of the scalp that get mistaken for like pilar cysts and things like that.
I think we discussed those in one of our Dermatology
Yes,
episodes.
yes, good.
It was a long time ago, though.
Mm-hmm.
Well, that's it. Unless Colleen has anything else to pimp the residents on this case.
Nothing else. That's all I know.
Yeah, so that was a good case to end up on. Kind of a rare bird, but once you see it, you'll know it for the rest of your life. I want to greatly thank Dr. Johnson and Dr. Tarbox again for being guest hosts here and bringing along your residents. I hope you guys had fun. Really, I just want to make these things fun like you guys do on your podcast. You know, just people can suck in this information and have a good time. Watch have dinner while they're watching the video or listening to the podcast. And so hope to have you guys on again sometime.
Thank you. It was so much fun. Those were great cases.
Yes, and thanks to all of the residents from our institutions and elsewhere for hanging out with us this evening.
Thank you guys for learning with us.
Thank
I love
you.
you guys.
Thank you. So we do this every week, not with such illustrious co-hosts, of course. I don't know what is our topic next week. I'm not even sure. I take this week to week. I might not even know until. But we do this every week, and next week we'll have some sort of themed unknowns. So just pop by. We'll have another post up in another 10 cases.
Yay! Thank you guys so much. This was so much fun.
Thank you. Thank you. It was a lot of fun for us too. Take care.
Bye.
Bye-bye, guys.